Ready.
All right. Good morning, everyone. Welcome to today's webinar on integrating primary care and behavioral health, making it work in our primary care clinic. My name is Bukam Rossetti, and I'm the Senior Project Manager with Care Compass Network. Before we get started with the presentation, I'd like to go over a few housekeeping items. One, today's webinar will be recorded and will be uploaded to CCN's website and YouTube pages. Two, we will be reserving the last 10 minutes of the presentation for Q&A. Please go ahead and type in your questions into the Q&A box at the bottom of your screen. And we will answer as many as we can towards the end of the presentation. So without further ado, I would like to introduce you to our presenters. Dr. Jessica Connor, Behavioral Health Consultant, and Melissa Gagnon, Office Manager from Northeast Pediatrics and Adolescent Medicine. Northeast Peds is one of CCN's 3AI project integration of behavioral health and primary care partners, serving patients in the Tompkins County area. Enjoy your webinar.
All right, good morning. So, welcome. Oh, no, it's already being finicky. There we go. Okay, so I'm glad you all are joining us this morning. I'm sure people are going to trickle in over the next coming minutes. Thank you, Bukam, for the introduction. As you said, please type questions in the Q&A box throughout, and we'll try and answer them as they come up as much as possible. To get started, we don't have any disclosures. We do appreciate the Care Compass Network for sponsoring this event and asking us to join because we love talking about this stuff. We do have some disclaimers though. So we're going to talk a lot about kind of the primary care behavioral health model in general and a lot about what we do at our clinic. And a lot of this stuff is really specific to what's going to work for your specific clinic. So just because this is how we do it, the details will often need to be shifted to work better for each individual clinic. Also, a lot of the information you're going to see on these slides is materials that I have taken from other people with permission from other clinics that I've worked in and from just the greater integrated care community and adapted. So by and large, I did not create any of this stuff. It's just been taken and adapted. And I think that's one of the things that I love a lot about this, the integrated care field is it really is this collaborative kind of place where people are not about reinventing the wheel, which is very helpful. You'll see some patient information later on. We're going to do some role plays. All of it's de-identified and shifted. And also, we are still learning. I have a consultant that I work with myself because I certainly do not have all this stuff figured out. But overall, today we're going to be going over different models of care integration, what we are doing here, how to make it kind of financially sustainable, and some resources as well. So to kind of dive right in, there's a lot of different models of integration that different clinics across the country, across the world are using. And we look at them on this continuum from minimal contact all the way up to like a fully integrated, collaborative model. And so there's no right or wrong place to be. Different populations and different clinics fit better into different categories. But it can be helpful to know what your clinic is at and what you want it to be and kind of have a sense of what the goals are. So on the far left, the minimal contact is the more traditional model of what's been out there. This is really the siloed care where you have mental health in one world and you have physical health in the other world, and they don't so much talk, they just go about their lives doing their own thing. Level 2, you'll see a bit more acknowledgement that the other one is really helpful and that we should be helping to facilitate the other one. So you might see a primary care office that has a list of therapists in the area, and they can give patients the list to those folks. Level 3 is I think where a good number of places have been moving toward, which is co-located care. So they might have, in a primary care clinic, they might have a therapist who works in the office, but they have different medical records. But all of the providers feel like they own their own patients, and there's overlap, but it's not being treated as like a team approach. It's okay, well, we conveniently have this person who also works here, and often in this model, the therapist who works in the office will try and more quickly get the patients in, but it's still very traditional therapy. Level 4 is where we're getting into more integration. So with this, there is the behavioral health person who is, in most of the models we're talking about today, is a social worker, marriage and family therapist, mental health counselor, psychologist, someone like that. They work within the team, and so it is more team-based care. But I think level 4 versus level 5, these are both the more integrated models. With level 4, there are really different cultures still going on. There might be a lot of clashing between the cultures because the culture of the medical world is really different than the culture in the mental health world. And so in level 5, there's a greater understanding of the different cultures and a really like melding of the cultures as well. And in that level 5, this theoretical level, there's an even playing field in terms of everyone's input is really weighed equally. I think more often in level 4, we see that the medical provider carries a bit more weight in terms of decision making and things like that. I would say our clinic lives somewhere between level 4 and level 5, depending on the day and the moment. Yeah. So here at Northeast Pediatrics, we're considered a patient-centered medical home, which is a designation we have through NCQA. And essentially what this means is that we're trying to really put patients first. We're really trying to not just have it, okay, you come in here and we treat whatever you have going on that day, and then we send you back into the world and you're on your own. We want to know which specialists you're going to. We want to have it, if you go to another doctor, like a specialist, and you have a confusing interaction, then you can come back to us and circle back, and we can kind of debrief that and think about, okay, what does that actually mean? What's going to actually get you to moving toward better health and those kinds of things. In this model, you'll see like the quadruple aims. So our goals are to improve the quality of patient experience. We're trying to improve staff satisfaction, which I think is something that isn't necessarily talked about as much in the world, but I think that's a really key part of the patient-centered medical home model. We're also looking to reduce costs. So this is the model under which we practice, and the guidelines that we try and move toward. Right. Other things with that?
The other things with NCQA and PCMH is that really you're trying to help the family drive their own care and drive their own medical decisions. It's less of the doctor says to do this, so do this, and more of these are some choices and suggestions I'm going to make, and you should do what you feel is best for you and your family. It kind of puts control back into the families. It gives control back to the family, and so when families have control over their healthcare like that, they're more apt to carry through with it or feel good about it, and they take a real stake in it. So that's also a big portion of the patient-centered medical home as well, and just the continuity of care across specialties, like Dr. Connor said. Yeah.
So that is one part of our ideological framework here, and the other part is this PCBH model, which is the primary care behavioral health. And so So with this, again, this is looking back at like the level 4, level 5 levels of integration that we were talking about earlier. So I'm a clinical psychologist, but I function here as a behavioral health consultant. I do not function as a therapist, and we'll get into that a bit more later. But so with this model, there are these behavioral health consultants, sometimes called behavioral health providers, or some other things. But I work really collaboratively on the team with the other people on our primary care team, which is largely medical doctors, DOs, NPs, PAs. We have a care manager. We have a lot of different levels of nursing staff. And beyond doing normal, like clinical intervention type things, I'm available anytime I'm in the office to do a warm handoff. So when a person comes in for a normal medical appointment, the physician can decide that they think it's a good idea for the patient to see me, and if the patient agrees, again with trying to get a lot of patient buy-in, then I can go in and see them the time that they're here for their appointment, which really helps with actually getting people to follow up with mental health recommendations. And also it's beyond just mental health too. There's a lot of behavioral health components. Ooh, throwing things. And so sometimes on follow-up visits, we'll see paired appointments. So they might see me first and then they'll see a medical provider, or the other way around, or it might get paired with a nursing visit. Again, just trying to make it as time effective and efficient for families as possible. And like I said, we really just want to increase the access to care, because primary care is the de facto mental health care in this country. That is where the mental health care is being done in this country. There are not enough therapists, psychiatrists, specialty mental health providers out there. And so people, by and large across the country, get their care in the primary care office in terms of caring for mental health and behavioral health concerns. And so with this model, we acknowledge that, and we bring the care to where the patient is. We don't sit around saying, well, this is how it should be. They should come to my office and we should sit there for an hour a week. We say, okay, what's really going on? What really is this family going to follow up on, and how can we make that work for them?
Oh yeah, okay. So what tends to be a challenge for most practices is understanding the difference between a BHC and a long-term therapist. And we all have this idea in our head that that a psychologist or a social worker or a counselor, that their main job is to do those things, right? They're there to counsel somebody until they can get on their way. When you look at the BHC and their role in a primary care office, it's best to think of it as also a primary care provider for the patients, but with a specialty. So maybe you're working with a patient and you catch a heart murmur and you say, this is beyond my expertise, so I am going to refer you to a cardiologist, right? Who is also a doctor, not in primary care, in cardiology. And you send them off to a referral to the cardiologist, and then you basically get back and forth so that you understand what's going on with that patient's heart, or gastroenterology, or infectious disease, whichever specialty. So like Dr. Connor here, yes, she's a clinical psychologist, but her specialty is behavioral health consultant. And that's what she does here. So she provides a lot of acute care for the mental and behavioral emotional problems that families are encountering. And when our provider is in a visit and this is what comes up, the parent's really concerned about behavioral issues or depression or anything like that, our provider has access to a specialist here in the building who can pop in, give some suggestions, maybe follow up with them, and then move on. It's acute, it's fast paced, just like primary care. And what Dr. Connor will do, or what a BHC would do, is at that point they would follow up with the patient to say, okay, we're going to get you connected with this service outside of our office. And it's a piece of navigation, if you will, that helps the patient get linked to what they need to be linked to. If you can think of it like that, it's much easier to integrate the position into the office, because you got to get away from the traditional therapist mindset and think about this is another primary care provider within the office that has a different area of specialty, is basically what that is. Go.
Right. So as Melissa was sharing, not a therapist, sure, not a therapist. I talk with my providers a lot about please never use the word therapist to describe me to a patient, because that just sets up poor expectations, because that is not what I'm there to do. My first client is the pediatrician, is the medical providers here. My job is to consult to them, provide consultation to those providers and help them with what they're asking me to do. They're not asking me to go and do care completely separate from them. Usually they're saying, hey, this problem came up. What can we do to help this person? So if I'm not accessible to the providers, then I'm not doing my job. And with that, I do not have any patients. I have 0 patients. I have medical providers who have a lot of patients. The providers here have 10,000 patients is about how many we see a year. And so the pediatricians have those patients and I consult for them. So I provide short-term behaviorally based support. I help families navigate complex systems. So I believe most of you all are in New York State. So we have various state systems that are very confusing and complicated. So we have like the Office of Mental Health, Office for People with Developmental Disabilities. We have the school systems and the testing that they're willing to do versus they won't do, and how can you get them to do that testing? We have community psychologists and if we travel far enough, developmental pediatricians who will do autism testing and psychological testing. And I don't do those things, but I help families figure out how to get those things to happen and help them figure out what's going to make sense for them to do at what point. I help connect them with specialty care. So if I'm meeting with someone and I'm like, oh, this person like needs a therapist, because I for sure think there's a huge role and huge need for a traditional therapy. If I see them and see that they need that, then I'm helping them get connected with that therapist. And in the meantime, I'm providing bridging support so they don't have to wait 2 months to get connected with a therapist. And in those 2 months, I can be starting work with them and get them moving in a positive direction and having them have a positive experience with a provider, and then they can go and connect with their longer term therapist. I'm also helping medical providers provide better care around mental health and behavioral health. So I'll do different formal and primarily informal trainings for providers. Also make suggestions regarding screening methods. So there was a question about the idea of incorporating ACE screens, which is the Adverse Childhood Events Screening tool, which is super helpful. I think like as a world, as we move to greater trauma-informed care, I think incorporating ACE screening is something that makes total sense to do. It's something we're currently trying to figure out how exactly to do and make a smooth workflow with our electronic medical record and with telehealth visits and just trying to figure out the flow. I think that in general, one thing I've been doing here is I've been working with the team to move toward greater use of screening tools in general. We don't yet have the ACE screening in place, but we do have a bunch of other screening tools that we use. Basically every well visit, a kiddo is getting a screening tool, primarily something like the SWIC developmental screen or the PSC, the Pediatric Symptom Checklist, or the PHQ-9 and CRAFT. Mm-hmm. And so I think that a role of the BHC in a lot of clinics is to help figure out how to effectively use screening tools, because I think a lot of it really is the preventive type work. I think it's really important, and trying to catch things early and trying to just not miss things in general. And to incorporate it, it's really been team decisions. You know, if you're not involving the nursing staff in decisions about how to do screening tools when they're the ones who are handing them the screening tools and scoring the screening tools and all those things, it's not going to work.
Can I speak to that?
Yeah.
Kayla, I do want to also say that one of my positions here was integrating a bunch of screenings into our workflow. And to kind of try to answer your question the best I can, like Dr. Connor said, one of a must is to have everybody involved, and it has to become a new normal, or it has to become a new part of the routine. You wouldn't do a visit without blood pressure. You wouldn't do a visit without height and weight. And it's the same type of thing. So you're going to look at this and you're going to say, okay, every child gets an ACEs screen, for instance, at these visits. And then you integrate that. Maybe they get it at check-in, they fill it out, the doctor reviews it, and then it gets scanned into their chart. That's one way to do it. Or maybe the nurse inputs all the answers into the chart. Either way, it just has to become part of, you just have to start. It just has to become part of the routine of the visit, like everything else. And that is getting buy-in from everybody on the team, because almost everybody becomes involved in it. So that's what I would say.
Yeah, one clinic, I did a training at Cherokee Health, they're down in Tennessee. They do a bunch of really wonderful immersive trainings. And they conceptualize it as mental health vitals that they do. So they'll do their physical vitals, like Melissa was sharing with the height, weight, blood pressure, and then they'll do their mental health vitals. They'll do a PHQ too, and I think they do another short one, but I think it's a great way to think about it.
Mm-hmm.
Okay, so those are the things I do. The things I don't do is traditional therapy. If, like I said, if someone needs therapy, if someone's in the primary care office, which is what we are primary care, and I'm providing primary care mental health. If they need specialty care, then we refer them out. Just like we would refer someone to a cardiologist or a dermatologist if they needed specialty care in those areas. I do make it part of my job to get to know the referral sources in my area, and to try and make that process as seamless as possible. So I will prepare lists for patients of, here are people who have openings and take your insurance. And that's a much easier way for patients to land with therapists versus just saying in an appointment, hey, you should probably see a therapist about this. And then they call a million therapists and they never return their calls. Also thinking back to the our patient-centered medical home model, my job is not to fix a patient. My job is not to fix their life. My goal is to engage the person in their own treatment, try and get, increase motivation, get that buy-in. But ultimately, in primary care, we give people the tools, and they can take those or not take them, which is, I think, a mental block that is really tough to work around. I know I've done a lot of supervision in my training around this, because it's really frustrating to see someone who's not making progress and not taking your suggestions. But with incorporating the patients into their treatment care team and making them really the leaders of their care team, I think it does take the pressure off of the providers to be fixing things. So that's really not our role. Our role is to give them the tools and to help them want to use them.
Yeah.
So some things I work with people on, I do a lot of mental health stuff still. So I'm working with a lot of depression, anxiety, stress, adjustment, the pandemic messing up people's well-being. We're certainly like the first the first providers people often see with things like eating disorders, and postpartum concerns. So often we're the kind of launching off point for those things as well. And we have a unique ability to catch that stuff as well, which is really helpful. I also do behavior concerns. So we're a pediatric office. We serve ages 0 to 21. So I see a lot of like tantruming behavior, acting out, helping parents figure out a strategy that's going to work for them, healthy eating, exercise, some substance use and tobacco cessation, not as much as when I was in college health, but it does come up. Another thing a BHC can do that I think is another separation from a more traditional therapist is the behavioral components of physical concerns. So sleep difficulties, asthma management, concussion management, like return to learn, diabetes management, whether it's the lifestyle kinds of stuff or adherence, medication adherence is something that the BHC is uniquely positioned to help with. I also do a good amount of help around like identity concerns, some help around sexual health concerns. I have a lot of training in trans health, And I think the primary care office is also a great place to be facilitating trans-affirming care. So I do a good amount of that and a good amount of sitting down with parents of teens and being like, it's okay that your teen is trans, it'll be fine. Also, I do a lot of work of like triaging a situation and trying to figure out what is going to be reasonable for the family. Is this a family who is going to do well with just a couple of skill building sessions? Is this a family who needs especially mental health? Is this a family who needs to get connected with more intensive services? As well as a lot of the times a provider will refer a patient to me with the question of, okay, this person might have ADHD or they might have behavior concerns. Like, should we be thinking about ADHD medicine? Okay, this person has depression. Should we be thinking about an antidepressant? Those kinds of things to try and determine course of treatment. So getting more into like the nitty gritty of what this looks like. So I try and keep my schedule like the primary care provider schedules. And so I have 9 pre-scheduled appointments each day. Well, up to 9, sometimes they don't all get filled. They're 30-minute appointments. I would say about 90% of my appointments are 30-minute appointments. Very rarely will I schedule a 45 or 60-minute appointment, but those are like exceedingly rare. And we're going to go through a role play of a clinical situation so you can see what I actually do in those 30 minutes and what gets put in and what gets left out. Typically, people are seeing me for an average of 1 to 6 sessions. I've run the numbers. The actual average is 2 appointments per patient on average. I certainly have those outliers who I'm seeing like 10 times. Usually that's people who are for whatever reason having a really difficult time connecting with a therapist. Also built into my schedule, which I'll show you a blank copy of my schedule, is room for warm handoffs. So warm handoffs can last anywhere from a 1 minute, like, hello, I'm Dr. Connor, please schedule with me at checkout, to a full session, depending on what's going on. So I do the 30-minute appointments and I space out the follow-up. One thing that I've gotten in the practice of doing is trying to ask patients when they think would be helpful to come back in, as opposed to me just assuming like, obviously you'll need to come back in a week or 2. And
that's patient-centered medical home stuff.
Right, and usually they're like, maybe in a month, and it's just meeting the patient again where they're at. Now if someone has like major safety concerns and I don't think that's appropriate, I would step in and tell them. But my follow-ups do tend to be more spaced out than traditional therapy would be. So I work 8.5-hour days with an hour lunch. And so I have 9 pre-scheduled half-hour appointments and then a lot of collateral care time for the warm handoffs, for talking with the providers, for writing notes, calling patients, calling other providers on the patient's care team, all of that stuff. My goal is to see about 10% of our population. And like I said, we see about 10,000 kids a year. So I'm aiming to see about 1,000 kids a year or 83 unique people each month, which I feel like I'm fairly close to. I've been here 1 year, so I'm about to go over all my 1-year numbers to see actually how many patients I saw this year. It should be interesting to see, but I don't think I'm too far off from that. And ideally, my goal is going to increase because anyone can benefit from a BHC appointment because again, it's not exclusively for someone with a major depressive disorder. It's for people who sometimes I feel stressed out and I would like some coping skills to deal with that. Another goal I have for my schedule is to have the 3rd next available appointment within 5 business days. That's just a metric that we often see, the 3rd next available appointment, for a gauge of how accessible someone actually is. And so again, if I'm not accessible, if patients aren't able to get in with me quickly, then I'm not doing my job. So that's a really key goal I have that I keep an eye on every single day. I write down when my 3rd next available appointment is because I haven't figured out how to make my medical record tell me. And with my schedule, if I'm not actively talking to a patient or I'm not on the phone, then I'm in a common space so that the providers can see that I'm right there and that it's really easy to talk to me, because out of sight, out of mind is a problem that I think a lot of clinics run into. And so I stay pretty near providers' faces so they remember that I'm here and that they can use me.
And interruptions, is that another slide?
That's a different slide.
Okay.
But yeah, so with my schedule, I do encourage providers to interrupt me. I tell them, please interrupt me no matter what I'm doing, except I did tell them not to interrupt this presentation. But otherwise, I say, no matter what I'm doing, please interrupt me, because then I can triage the situation and figure out what's going on and where I'm needed most. Okay, so like I said, every day I like write down data about what I'm doing and what I'm seeing, and my electronic medical record pulls a lot of these numbers for me as well. But I keep really close track of like, what am I doing? Who am I seeing? And I'm just kind of a person who likes data anyway. So these are my numbers. I have some other, this isn't super updated. This was updated as of June of this year, but you can see the number, the blue is how many pre-scheduled appointments I had for the month. The red is how many warm handoffs I had in April during the pandemic major shutdown, when we like stopped having most well visits. I didn't have a lot of warm handoffs. Although through the pandemic, my numbers have been kind of consistent, which is interesting. But anyways, you'll see that my third next available is really sticking between the 0 and 5 days. It's got a little bit dicey in February, but otherwise staying pretty good. You'll see that, right, the number of sessions per patient is low. Average of, well, April to June was 2.3. My fill rate is pretty high. I tend to have most of my pre-booked appointments filled by the day of. I'd love to have my warm handoff numbers be higher, but there's one of me and 13 providers. So that's a thing that sometimes slows down my warm handoff numbers that we are working on.
And I think what this also really shows or tells the story of is that a BHC is, if properly utilized, is really utilized. There's a need for a BHC, and the feedback that we have gotten from providers here, doctors, APPs have all said that having Dr. Connor here in-house to be a bridge, to give suggestions and things like that for families, and to be a support system for the providers themselves has been a huge help. And nobody wants to work without her now, right? So this is how do we ramp up the program now, and how do we bring even more? Because at the end of the day, what's so great about the BHC, besides the fact that she's right here, is that the providers can move on to their next patient, and she can fill in those gaps or those needs that maybe they don't have the expertise in. And these graphs that you're looking at and spreadsheets show exactly that she's used constantly. And even when we weren't seeing patients in-house because of COVID, we weren't even getting a ton of video visits, Dr. Connor was still being utilized by patients pretty consistently and pretty well. So
yeah, there's this interesting paradoxical relationship that we see in some clinics where if you're really afraid of being interrupted and you're really afraid of warm handoffs, that you end up being underutilized because providers think that you're not available, and so then they stop referring people to you, even though you're just like trying to be there, like focused on the appointment that you're having. And so I just try and minimize my anxiety around things, and now I'm pretty well in the habit of it. But as much as I've been able to open my door figuratively and literally to being open to seeing all of our patients wherever, whenever, I always tell the providers there's no bad warm handoff, there's no bad referral. The more I'm actually able to keep balance. I think too, like if patients feel like it's going to be really hard to get in somewhere, they're like, okay, well, I better book this appointment keep this appointment on the books. and I better book a lot of appointments and then they show up and they don't really need care, versus I tell people that it's always really easy to get in with me, which is true. Looking back at my third next available, and then they don't feel as stressed out that they need to schedule things ahead of time.
Right. Well, and part of that is the model of springboarding people to their next help point in the community or wherever. If Dr. Connor was keeping everybody on for months at a time or doing multiple sessions, she wouldn't have the availability that she has. So this is part of the importance of the model, that it's acute, it's quick, and it's a springboard. And the other thing is too, when you're interrupting patients in these warm, when she's talking with a patient or working with a patient and a provider interrupts, it also shows the patient that this is the model that we use, that Dr. Connor is available to people. You're not going to be in here for an hour chatting out things, forever. So it kind of serves two purposes.
Expectation management is really a lot of it, because most people have never experienced a behavioral health consultant before. A lot of people haven't experienced therapy before, but some people have, and they walk in expecting it to be therapy, which is why in the second sentence of when I talk to people, as you'll see shortly, I tell them I'm not a therapist. But trying to really set those expectations up early so that you're able to provide the care that you're able to provide, and you're not taking on more than what is the role. Where did that chat go? Okay, so this is what my schedule looks like. This is a blank schedule of mine. Now that we're closer to October, some of this stuff is filled in. I don't know where that went. If someone sent a chat message, it has disappeared for me, so please send again.
Did you have the Q&A? It didn't look like it was.
It didn't come through there. Okay.
That's very weird.
But anyway, this is what my schedule looks like. And so you'll see that the white ones are appointments that people can book into, and the gray ones are things that people cannot book into, although I change things around all the time. This is 12:30 to 1:30 is my lunch, so I try not to book over that. But otherwise, the gray time is, again, when I'm writing my notes, when I'm talking with providers, when I'm doing those kinds of things. I tell patients it's going to be a 20 to 30 minute appointment so that I can be ready for the next 30-minute appointment. And by the time the day rolls around, usually all the appointments are filled. I give myself a half-hour window at the end of the day before I leave so that I can leave on time. So what the workflow typically looks like, so by and large, someone will come in, see a primary care doctor for whatever reason, and that provider will decide that, hey, it might be helpful for them to have a BHC appointment. So they might do that right there in the moment. They might say like, hey, let me see if Dr. Connor is available, hang tight right here. And then they will give me a call or come to my office and interrupt what I'm doing. And then I'll figure out if I can take the warm handoff in that moment. If I need to tell them I'll be ready for a warm handoff in 5 minutes, or if I hear the situation and say, just go ahead and have them schedule at checkout. So they might do a warm handoff there in the moment. They might send me a message through the electronic medical record after the appointment, say, hey, I saw this person, can you follow up with them? Or they might just have the person schedule at checkout, and then that person will pop into my schedule, and I'll look back at their last note and see, oh, they talked about stress and the provider recommended they come and see me. Like I said, I really want people to interrupt my sessions because I want to be accessible to providers in that moment, and I really want to be able to triage that moment. You know, if I have a pre-scheduled appointment with someone and we're talking about weight loss and they've wanted to lose weight for the past decade, and there's a teen who's here for a well visit and they're actively suicidal, then I'm going to pause my current session and go talk to that person, the person who's suicidal, because that's where I'm needed. I get very used to reviewing charts really rapidly, and I'm very comfortable walking into a situation knowing basically nothing about the situation, which I know can feel really scary at first. I actually find it really freeing because I feel like there's not as much pressure on me. I'm not walking in expected to know everything that's ever happened to this person. I walk in knowing, hey, this person is trans and their parents don't know and they're kind of freaking out about it. And we figure it out. But I have my laptop glued to me as a person because I have to always be ready to pull up a chart and start looking through things whenever. The nice thing about being in primary care is that we usually have data. You know, we're not walking in being like, well, we have no idea who this person is. Usually this person's been coming to our clinic for several years. We have a growth chart on that kid so I can see, wow, they started gaining weight really rapidly 2 years ago. Something weird probably happened then. Or, oh man, like their BMI is plummeting off. Like, does this kid have an eating disorder? Maybe. So I look at the last appointment note, typically their problem list, which is a great thing to just glance at and be like, oh, this kid has diabetes or whatever. Like I said, we're trying to implement screening tools in basically every one of our well visits. So you'll be able to, so we can look back and see, okay, this is what this kid's PHQ-9 has been over the past 4 years. I look at if they've previously been seen by BHC. I look at their insurance because that gives me clues about specialty mental health options that are going to be available to them. And some of our insurances our clinic participates in, but I don't participate in. So I want to know that so I can tell people that and they don't get surprise bills. I look at their medicine list. So a medical provider will be like, hey, here's this person I want you to see. Maybe I'll have 10 seconds to look through their medical record before a warm handoff, and maybe I have 10 minutes before they come in for the appointment. But I look through their chart to whatever level. I have the appointment, and then a really important part is I always circle back to the provider.
We have a question from your read.
No, I'll read it after I say this.
Okay.
So when I circle back to the provider who referred them to me, I'm either talking to them in person, especially if it's something if it's a warm handoff, I'm basically always circling back unless they've already moved on with their schedule. Or if it's something that I'm like, oh, like this person is like very concerning, I'll talk with them in person. Otherwise, I'll be sending a message through our medical record and letting them know what's going on, what I'm noticing, and you'll see an example of that later. So there's a question of, do I do suicide risk assessment / screenings? What assessment do I use? A lot of times the crisis center I work at gets referrals from doctor's offices and patients who are very frustrated because they made a big statement with no intent / plan. Yeah, providers really freak out about suicide if they feel like they don't know what to do with it. Then they really get concerned and they're like, okay, well, like if you said the word suicide, like I need you to go and talk to someone about that, which I think is a really good benefit of the BHC model because I save people a lot of care that they don't need, inappropriate care. So in terms of suicide risk assessment / screenings, I have talked with our triage nurse, so the person who takes our incoming calls, about the CSSRS, which actually, if you go to their website, 1, it's free and available, which I love. 2, it helps to like sort out, it gives like specific verbiage, around, you know, word questions to ask for instead of just like, this person says they have thoughts of suicide, I'm gonna panic. And it gives suggested pathways about what to do with that person. And we kind of refine that for our clinic. We also, like I said, for our teenage well visits, every single teenage well visits gets the full PHQ-9 because I prefer it over the PHQ-2 just a little bit. And so there's a suicide question on there. In practice, I do my own type of safety screening, questions along the lines of the CSSRS, but not as formal as it. And like 2 times over the past year, we've ended up sending someone to the emergency room to be assessed. And we do have the training so that we have the legal capabilities. Myself and the pediatricians and our nurse manager can fill out the legal paperwork to have someone transported against their will. But yeah, I mean, I think that the providers here have gotten a lot less panicked and a lot savvier at knowing, and a lot of them, even when I got here, were very good at this already, at knowing, well, this person is saying they have these concerns, but there aren't any actual safety concerns right here at the moment. But I think that the more that the providers feel like they have an easy, accessible resource, the less they overreact to things. So I'm not surprised that you end up getting a lot of referrals from patients who have no intent, because I bet the provider was really freaked out by it. I don't know if that's the right question. Yeah, the right button to push when it does that, but that's what I'm doing.
There's another one.
Well, this is the thing. Oh, too far. Maybe not. Yeah, so someone, maybe the team over at Care Compass Network is sending us chats and we can't figure out how to read those, unfortunately. If you send them through the Q&A, we could probably read them, but sorry that you're sending us secret messages that we can't read. Okay, but so like I said, after the appointment, I circled back with the referring provider, and so this is what this looks like. This is literally pulled from a thing that I sent to a provider, our provider, Kathleen Murphy here. So I attach the link to the note itself, but I also give a quick synopsis of the note, because I assume that providers aren't taking the time to read every single note I send them, because they want me to send them every single note I write about a person. And like I said, I see 9 people a day and I see a lot of people, so they're probably not reading the full notes, which wouldn't be a good use of their time anyway. So I give them a description of things that I think they should know, right? So thank you so much for this referral, being very nice to the providers, really wanting to keep them referring people to me. As discussed, so this one I talked with Kathleen in person, but then I also circled back and sent the documentation, because it's good to have things written in the medical record, because if it's not in the medical record, it didn't happen, so should always document. As discussed, her weight is on the low side, and I think it would be great if you could check in with her about that. I did start the conversation about encouraging her to eat more regularly. I'm going to see her again in 2 weeks, and right now I have her focusing on decreasing naps, eating more, and completing her college application. Let me know if you have any questions or concerns. Another thanks, again, being nice. And so that's what that typically looks like for circling back with the providers. So looking more into the nitty gritty, and again, please send questions as you all have them. It's weird not like being able to see your faces and having feedback. It kind of feels like we're talking to no one. So send questions as you have them. But what appointments look like is, again, so I've got 30 minutes, really 20 to 30 minutes. I really aim to get it to be like 25 minutes so that I have like a second to breathe before the next one. But I do a 1 to 2 minute introduction where I'm doing limits of confidentiality and where I'm setting up expectations. Then I do my functional assessment. So I'm not looking to do a complete like clinical interview of the person. If I was going to do a complete clinical interview, I would need 1 to 2 hours. Don't have that. So I'm doing a functional assessment based on the presenting concern, really trying to get the what, where, when, why, how questions of the presenting concern. And then some like general assessment kinds of things to get a bigger picture of what's going on and to not miss something that's like very important for me to know. Then I go into the advise portion. This is all based off of like Robinson and Ryder's book on integrated primary care. I think I have it listed at the end of resources because they're like the geniuses of this stuff. They're the ones who came up with this, like it's like the 5 A's model, or at least they write about it. I'm assuming they came up with it, but maybe that's not true. So advise, so I discuss treatment options with the family, get the agreement. There's no point in me like trying to teach someone about behavioral activation if they're totally uninterested in doing it. So I try and figure out what is the family actually interested in and what do they actually want to do. The assist portion is the intervention portion. So I'm doing a lot of the intervention is like psychoeducation, teaching families about mental health stuff. And then other normal interventions. I do a lot of CBT, so a lot of CBT interventions. I have an intervention in every session. Again, thinking about the primary care model, you don't go to a primary care appointment. Like if you have a rash and you go in and they spend all their time learning about the rash and then they say, come back in a week and I'll tell you how to help with the rash, you'd be pretty mad, right? And so so it's the same thing where I'm trying to get enough history so I can give them an intervention. I'm not going to get their whole history, but there will be other appointments where I can get that. So I'm trying to get enough so I can give them a place to start, get them started moving in a better direction. Sometimes the intervention is just like validation and a little bit of psychoeducation. That's okay, but there's some intervention in every appointment. And then I'm spend a minute arranging things. When are you going to follow up? What's that going to look like? What is your action item to go away with from the intervention? My warm handoffs, like I said, could be 1 minute, could be 30 minutes. So it might just be like half of the introduction again, like, hi, I'm Dr. Connor, please schedule an appointment with me. Do you have any questions right now? Or it might be all of this stuff. Okay, so we're gonna go through a role play where Melissa is going to be
The depressed teenager in scenario 1.
Okay, so here are 4 different scenarios that if you guys could send which one you would prefer to see through the question and answer, that would be great, because I'm only going to do one of them. Or if you want to make up a scenario that you're like, I wonder what you would do with this, then you can send us your own scenario too. We're going to do a second role play of a warm handoff later on. But these are things that I see basically every day. So depression concerns that came up in a well visit, or a younger kiddo who, like I said, maybe this is ADHD, maybe it's like behavioral concerns. Could do a 9-year-old who has internalizing concerns, which is how it would come up on the PSC. The screening tool we use either gives, it has 3 subscales: internalizing, externalizing, and attention concerns. Or a 17-year-old with sleep problems who's already working with a therapist on mental health stuff, but also the therapist isn't really helping with the sleep things. So if you have a preference, send it through the Q&A in the next 30 seconds, or I'm just gonna pick one at random. Or you could pick, since you're gonna be the person. This is again, we see 0 to 21. So I'm sure that many of you wonderful folks listening are not in the pediatric world. That's why I tried to aim more of it toward our young adults who you would see. But I have worked in the adult BHC world. I just don't do it as of late. Who would you like to be?
I think the 20-year-old or the 17-year-old would be good for the demographic that we're presenting to.
Okay, so let's just dive into the 20-year-old. So this is a kid, young adult technically, who showed up to a well visit, just their regularly scheduled 20-year well visit. We gave them the PHQ-9 like we give to everyone. They scored 11. Okay, we have 1 vote for the 20-year-old, so great, we're gonna go ahead with that. Still don't know if that was the right button.
I think that's fine.
That's what I'm gonna do. So, oh, there we
Here
go.
they are.
Yes. Bukam, we've finally been able to read the chat questions. It just took a minute. Okay, on the PHQ-9, they didn't have any safety concerns that came up, which means on the last question of the 9 questions, they answered no. And I know I'm just like throwing out a lot of names for screening tools that maybe some of you guys know and maybe you don't. The ones we use are all free and available, because why spend money when we don't have to? But one other important thing about my BHC life is that I do concurrent documentation. I wouldn't survive having so many appointments with so many humans if I did not do concurrent documentation. And so in my session, I am sitting on my laptop and I'm tippity typing away on my laptop the whole time I'm talking to a person. Now I do try and make eye contact during this, but they expect me to be on my computer, which is again something that took me a long time to get over. And once I got over it, it just made my life so much easier. I also think it helps set up the expectations that like, this is not going to be you laying down on a couch and spilling your innermost things with me. It's going to be, okay, what's going on and how can we help? So during this role play, you'll get a chance to watch me type. So here's a note that I started. This is how my notes pop up. Like I said, this is a test patient, so this is not a real person. So right, theoretically, this person also has asthma and they're on amoxicillin for something. But I put a good amount of time into making my notes do a lot of the work for me, because you want to use the EHR to your advantage. So I'll walk into a room and I'll already have this up. All this stuff pops up, okay? All right, so this is a pre-scheduled appointment. Oh no, it was set up, no, so this is not a warm handoff. This is a pre-scheduled appointment. They saw that provider for that well visit. The provider said, come back and make an appointment with Dr. Connor, okay? So we're not using waiting rooms right now, but we're gonna pretend like this was an in-person visit, because I am doing in-person and video visits right now. I would call the person in their car because they called and said they arrived. I call them, say, hey, I'll meet you at the front door. Meanwhile, I'm walking and typing this stuff. I'm saying they were referred by their primary care provider, Dr. Akinyeti here. And this is what so this says 6, but they're 20. Okay, so we're just gonna go with that. Okay, so you ready?
I'm
Okay.
I don't know. Yeah, I'm depressed.
Okay, fair enough. And so you'll see the timing is starting at 9:56 on my clock here. Okay. So welcome, I'm Dr. Connor. I'm the behavioral health consultant here at the office.
Mm-hmm.
So what that means is I'm a psychologist by training, but the way I work here is different than how like a therapist or school psychologist might work.
Okay.
I work on the team with Dr. Akinyeti, all the other providers here, and I see people anytime there are concerns going on where our well-being is impacted by things like moods, behaviors, that kind of thing. So we're going to talk here today for about 20 to 30 minutes. Depending on what seems like it'll be helpful, we might just meet this one time, or we might meet for a handful of follow-up sessions. We'll think about what makes sense.
Okay.
Most of what we talk about will stay between you and I, but there are a couple of exceptions to know about. So I write notes in our medical record here. I'm a mandated reporter of things that are safety concerns, and I bill through insurance, so insurance will know that we're talking.
Okay.
Questions about any of that stuff?
No, I don't think so.
No? Okay. If you think of questions, let me know.
Okay.
So I was able to get a chance to talk with Dr. Akinyeti, and I heard that there were concerns going on maybe around mood things. Is that what you want to talk about today?
Yeah, I noticed it like a week ago or more maybe. I guess a month ago, not a week ago, but I feel a little bit overwhelmed and I have a hard time getting out of bed.
Mm-hmm.
And just like my friends have called a few times and I don't really have interest in talking to them. So I don't love feeling like that, you know, so.
Totally fair. I wouldn't love feeling like that either.
No, it's funny.
Okay, so you said it's going on for about a week?
No, I think it's a month. I said a week,
month?
but I meant a month.
Okay.
Yeah.
Anything that changed about a month ago?
Not really.
But just noticing more overwhelmed.
Yeah, like I feel like just my whole mood is like a little bit more depressed than it normally is. Like I'm pretty an exuberant person normally and I just don't have it in me.
Mm-hmm. That makes sense. Okay. And other changes you've noticed lately? Are there other things about the mood stuff?
I mean, it might be a little edgy or cranky.
Mm-hmm.
And also I don't have the greatest appetite, but that's really it.
Do you find that you're eating less or you're just less hungry?
I'm just less hungry. And I just want to be able to get like back to the swing of myself, you know?
Mm-hmm. Totally fair. Okay, what about, do you find yourself worrying about things more?
Well, I lay in bed a lot at night and think about like the next day or I do take a night class because I'm working and I take a night class. So sometimes I lay in bed and just kind of think about my night class, and it's hard to turn off my brain, you know. Or I think about things I have to do at work the next day, and I don't want to mess it up, and I have a hard time falling asleep from it.
Okay. About how long do you think it takes you to fall asleep?
Like sometimes an hour, sometimes 2.
What time do you typically try and fall asleep?
Like around 10.
Okay. And when do you get up in the morning?
I get up at 6 if I can get up. Sometimes I like hit the snooze button 30 times until it's like 7.
Yeah.
You know,
Do you ever end up being late to things because of it?
I'm late all the time.
Is that mainly, what do you have first thing in the morning? Is it school? Is it work?
It's work.
Work. Okay. And where are you working?
Well, I work at Best Buy.
And about how many hours a week?
30
Okay. And you said night classes?
night class. Yeah.
Where is that at?
When it's online.
Okay.
But it's like a class, but it's like virtual.
Sure, that makes sense.
And that's at 7 on Wednesdays.
Okay. Do you find yourself feeling like you're almost moving in slow motion sometimes?
No, actually, I don't feel like I'm moving in slow motion. So sometimes, but mainly I feel like my brain is racing and I can't always keep up with it.
Yeah, that makes sense.
So maybe I'm moving in slow motion, but my brain is like going a little haywire.
Are there things that you tend to worry about, or can it be like anything?
It's like anything. I think the things keeping me in bed is I'm just overwhelmed, right? Maybe with class and stuff, so.
What are the main stressors in your life?
Well, work can be a little stressful. I mean, there's some strong personalities. And my schedule can sometimes be stressful because I have to do night class, and so I'm tired because I don't sleep well, and then I'm trying to keep up with what I'm learning, and then also dealing with difficult personalities at work. Those are my main stressors. I mean, everything in the family life seems to be okay, so.
Okay. Who do you live with?
I live by myself in an apartment.
Any pets?
Mm-mm.
Okay. What about thoughts coming up of wanting to end your life?
No,
No?
never felt that way.
Never in your life?
No.
What about thoughts of wanting to like cut, burn, scratch, that kind of thing?
I've cut my leg before.
When was the most recent time?
I think it was quite a while. It was months ago. I got really frustrated, and I got really frustrated, and I just didn't know what to do, so I just cut my leg a little.
Yeah.
I felt like it released some sort of frustration, but
Yeah.
you know, then that kind of hurt. So
Yeah. Did you end up seeking medical care for
no,
it?
it wasn't like a big cut. I used the end of a paper clip and just like scraped myself.
Was it just that one time, or were there times before that too?
No, just that time.
Ongoing urges to do that?
No, not really anymore. Never thought I'd be a cutter.
You know, it's interesting because it is something that, you know, like if we looked at your brain scan during it, it does release some of that energy, and it can really shift your focus as well.
Yeah.
You know, on the spectrum of coping skills, from like things that work everywhere all the time to things that work only in really selective occasions, I would say it's further on this side of the scale.
Yeah.
It's not the worst thing you could do, but probably not the best coping skill either. So sometimes it's helpful for us to kind of strategize other coping skills that you have a bit more flexibility with and don't leave you with the same pain.
Yeah.
Okay. Other questions for you. Big scary things in your life at any point: abuse, car accidents, surgeries.
No, really, I did have surgery on my foot in high school. That was not a big deal. And my parents have always been very supportive and very upbeat people, so.
Any mental health concerns with family members? Depression, anxiety?
I
things
think
like
my
that?
dad maybe, I don't know this for sure, but I think maybe he has OCD. He likes everything like a certain way, you know, the
Yeah.
house has to be a certain way, and he's not like crazy or mean about it, it just
Sure.
stresses him out,
Yeah.
right? He's just like, and that was growing up, right? That
Yeah.
would like stress him out, he wanted like that way.
Do you know if you ever did any like therapy or medicine, or just
Mm-mm.
kind of dealt with it?
Now he just dealt with it.
Okay.
I don't even think he knows.
That's fair. That's fair. A lot of people don't. Okay, so some more questions just to get a bigger picture of things. Cigarette or vaping use?
No.
What's your typical alcohol use like?
Sometimes I have I'll have some beers if I'm hanging out with friends, but
About how often is that?
well, it hasn't been often lately, but before it was probably like once a week, once every 2 weeks, nothing major.
Okay. And what about marijuana use?
No marijuana use,
Other drugs?
no other drugs.
Caffeine?
I like caffeine.
About how much a day?
Probably like 3 cups a day.
Coffee, tea,
Coffee,
and around what time of day?
usually in the morning when I'm running late.
Mm-hmm.
Then again, like on my break at Best Buy, I'll have some coffee in the break room. And then usually that's kind of it. If I have night class, then I guess I go to like on Wednesdays, I'll go to a 3rd cup before class.
Around what time is break at work?
11.
Okay. And on the Wednesday night class days, around what time are you
Then
drinking?
I get done work at 6, so then I'll have a coffee for my drive back to my apartment, and then I log on to my class at 7.
Do you notice any difference in terms of how long it takes you to fall asleep on Wednesdays versus the other days?
Sometimes, right, that the caffeine would make me stay up a little later, and I definitely recognize that, but there are days where I don't have it, and I have just as hard of a time.
Okay. So I would keep an eye on it. You might find that it does make it harder to fall asleep. If so, I would just try and pull that back a little bit earlier during the day.
Okay.
But if it's not bothering you, then it's fine to continue to do.
Okay.
What about any over-the-counter meds that you're taking right now? Vitamins, herbals?
I take
supplements?
Zyrtec for my allergies.
Anything else?
Flonase nasal spray, also for allergies.
Okay. And any sleep supplements that you've tried?
No, I've definitely taken gummy melatonin before.
Are you still taking that or no?
No,
Was it helpful at all?
not really.
Yeah, it tends to be pretty hit or miss. Most of the over-the-counter and even the prescription sleep meds tend to be pretty hit or miss with people. There are behavior strategies that we can talk about that tend to be like the gold line treatment.
All right, that would be good.
Concerns with things like sex, sexuality, gender identity.
Not today. I'm not with anybody.
Concerns with things like eating, body image.
No, I mean, I'm not eating as much as I used to because I just don't really feel hungry, but
Right.
I try to listen to my body like that. You know, if I'm not hungry, I don't eat.
And about how many times a day do you think you're eating?
Probably twice on average.
Twice?
Yeah.
One thing that's a little bit tricky that you might find is that if we're not eating consistently enough, that it ends up messing with our hunger cues. And which is this like weird thing. You think if you're eating less that you would end up being more hungry, but a lot of the time what we see is if you get out of the habit of eating consistently that you end up not being as hungry. You might play around with trying to eat a few more times a day, more like 4 to 6 times. It might help with the hunger some too.
But if I'm not hungry, and what would be the reason for me to eat?
To keep up your energy. I mean,
Yes.
eating helps stabilize our mood. It also just helps us kind of be alive people who can regenerate our cells and all of those things and,
All right.
and keep up our energy, especially with your schedule that you've got all these things moving on. It's really hard for us to be like calm thinking people if we don't have the consistent meals going on. And it doesn't have to be giant meals, right? But even if you can eat, small things kind of throughout the day, it might leave you in a bit of a better place.
All right,
I don't think it'd be everything, but it might just be worth playing around with.
I mean, I can try.
What kinds of things do you do for fun?
Well, rollerblade
Uh-huh.
and play cards and kayak. And I was having like movie nights with my friends before COVID. That was fun.
Yeah. Are you still talking with friends?
Yeah, once in a while when I feel like it.
What would you say some of your strengths are? What are some things that you're good at?
I'm a pretty friendly person, and I'm a hard worker, and I would say I'm good at keeping the peace within my siblings.
How many siblings?
3.
And growing up, who did you live with?
Plus, I'm pretty creative.
Yeah?
Yeah, I think so.
You
I
said,
grew up in living with my mom and my dad, and my sister and two brothers.
and where are you within that? Oldest, youngest,
I'm
someone
right out in the middle.
Fair enough. Okay. I know we haven't been talking that long, but are there things we haven't talked about yet that feels like a big part of what's going on for you?
I do think that like COVID has made it very hard for me because I'm a pretty social person and I've had to keep a lot of distance, and then I feel like maybe that just went really extreme and now I'm just like not into it at all.
Yeah.
Even like hanging out with people.
Yep.
And maybe, I couldn't think of anything major in my life going on, but maybe just COVID as a blanket in general has kind of left me feeling blasé.
That's totally reasonable. I think that I'm seeing a lot of that, like and especially like people who are more likely to be worried, they're worrying more. People who are more likely to be sad are more sad. People who are more likely to be angry are more angry lately. That the pandemic is really just bringing out some tough things for most people. I think you're totally right that a lot of it is just like when we're in the pattern of doing things that feel good, we tend to feel good. And once that is really disrupted, it can just be a major blow.
Right, so like what do I do?
Very reasonable question. So there are different things we can think about depending on what you would be interested in. Okay, so what I hear from you is that over the past month, mood has been really just kind of blah, that like you haven't been interested in people as much, haven't been interested in eating as much, been more stressed out by your schedule. And it sounds like you've kept the stressful parts of your schedule and the fun things have dropped off somewhat. So probably the balance is not feeling as good as it used to be.
Legit.
Yeah. So some things you can think about trying. So in general, I think that you have some level of kind of like depression kind of thing going on. I don't think it's a full on like major depressive episode that we have to like panic about.
Okay, good.
But I think there's a level of depression here and probably some parts of anxiety too. And so when we think about those things, there's some different options to think about. So we could meet for a handful of sessions and talk about kind of skills and strategies to try. If you know right away that you're like, I want to work with a therapist and I want to do like weekly sessions for like an hour, I'd be happy to help connect you with a therapist. Sometimes we even think about doing therapy and medicine together. That's not so much where I'm thinking for you based off of what you're experiencing from what I'm hearing from you, although it could be something we consider if things aren't starting to feel better.
I think I just feel more comfortable meeting with you a handful of times because it's not like I have a huge history with this or that I feel like I'm like unreachable. Like I don't feel like my old self is unreachable. I just need help getting back there. And then I guess if that doesn't work, maybe we could go to long-term therapy.
Absolutely, and we can kind of keep an eye on it and play it by ear, but I think that makes total sense. So a lot of the times what ends up happening is that we feel bad and then we don't feel as much like doing the things that we used to do. It takes a lot of energy to do those things, it's not convenient, we just would rather kind of be in our bed. And so we do less fun stuff. And then we feel worse. And then we definitely feel like doing less stuff. And we get stuck in this kind of downward spiral.
Right, that's where I feel like, that's exactly where I feel like I am, yeah.
Yep, and that it happens to a ton of people all the time. What tends to be helpful is to slowly work backwards through that cycle, starting with changing our actions in small and gradual ways, because if we just wait around to feel better, it doesn't tend to work that way. Versus if we can start engaging in things that used to be fun, then it tends to help our mood, and then we can do more things, and we work our way back out through that cycle. One thing to keep in mind is wanting to start with smaller goals, right? We don't want to say, okay, tomorrow you need to go run a marathon, because that's not going to happen, and then you're going to feel bad that didn't happen, right? So we want to start small with something that's going to feel realistic. So can you think of something over the next couple of weeks that you could focus on kind of reincorporating?
Maybe I could just like reach out to my friends. That's pretty easy. I could text them or something or call.
And how often would you want to do that?
Let's just start with once a week.
And do you have a certain friend in mind who would be easiest to reach out to?
Yeah, so I'll reach out to Heather.
Heather? And do you think you'd be texting, calling?
I'll probably text her.
Okay. How realistic does that feel as a goal?
That's realistic. I can text Heather. Yeah.
Okay. So I think that's a really good place to start. Again, like I think that at first it really might feel like you're faking it. If at first it feels like this is not fun, I don't want to be doing that, that's totally okay. I don't want you to be freaked out by that. I just want you to do it anyway. I would try to do it at the beginning of the week as opposed to waiting till the end of the week. Okay. So the earlier we can reach out, the more likely it is to happen. But I would say that would be the place to start, would be trying to reach out to Heather once a week.
Okay.
Trying to, also keep this stuff in perspective. We're in a pandemic right now.
Mm-hmm.
You're not feeling bad kind of out of the blue. The world is really crazy and nutso, and you're not having as much access to the fun kinds of things that help you maintain your well-being. So I do think it's likely that things are going to get better for you. I think that it's just getting back in the practice of doing the things that used to be helpful.
Okay. That's promising anyway.
The other thing I would say, right, so just to circle back on it, keep an eye on the caffeine just in terms of if it's impacting sleep.
Okay.
Maybe think about trying to eat more consistently. You could try it for a day or two, and if you're like, no, this is garbage and isn't making me feel better, you can stop, but it might be worth giving a try too. The other thing I would say with sleep is that one thing that tends to be tricky, so right now you're going to bed at like 10, getting to sleep probably around 11 to 12, up at 6. So you're getting 6 to 7 hours of sleep. People your age, we're aiming for 7 to 9 hours of sleep. So it's not terribly far off, but would need something a little bit more. It sounds like we can't shift wake up time.
Yeah.
And the other tricky thing is that, well, what are you doing for the 1 to 2 hours that you're waiting to fall asleep?
Well, sometimes I'm just laying there, and then sometimes I check out Instagram.
Uh-huh.
Because I know they say it's not good for you to do that before you go to sleep, but a lot of times it makes me go to sleep. I get very tired on Instagram,
And it very well might work for you. And if it works for you, I'm not worried about it.
Mm-hmm.
The fact that it's still taking an hour to 2 tells me that maybe it's not working for you.
So I think the times that it's not working isn't necessarily the time I'm even on Instagram. It's the time that I'm laying in bed fretting over my next day.
Yeah. That makes total sense. So something you could try with that is trying to plan for at 9:30, even trying to write down the things that you're worrying about.
Okay.
And just have a running list of it. Sometimes it can get turned into a to-do list. Other times we just leave it, but sometimes that act of writing it down on paper gets it a bit more off of your brain.
Mm-hmm.
So I would do that, but then I would still give yourself a bit of a buffer where you can do kind of relaxing wind down type routine, right? Things.
Mm-hmm.
Ideally, you're not on screens during that, because when you look at screens, your brain thinks you're looking at the sun, and then your brain is like, it's time to be awake because it thinks it's the sun. And so like I said, if it's not a problem for you, then it's fine to do. But if this alone isn't helping, but writing things down, then we might think about playing around with the screens. We might also play around with how much you're laying in bed while you're awake. Because there's some things we can do around that might be annoying to do, but will be helpful if this alone doesn't help.
Okay.
Does that make sense?
Mm-hmm.
What questions do you have about that?
I don't know. That was just a lot.
I know.
I don't have any questions that I know of.
Okay. So that was a lot. Main takeaways.
Are you asking me?
I was going to tell them,
Okay.
although if you want to tell me, I will take that too.
Okay, so call Heather
Mm-hmm.
Earlier in the week,
Mhm.
right? And I don't try to give myself some time before falling asleep to kind of unwind,
Mhm.
or before I go to bed to unwind. And if I have a lot of frets, I should write them down.
Mhm.
Try to eat a little bit more consistently to see if that helps with my energy and mood.
Mhm.
And I think and watch the caffeine intake.
just try and pay attention to it. You don't have to change it. And with all these things, it can be hard to make a million changes at once.
Yeah.
So I would prioritize talking to the friend.
Okay.
The other things we can kind of keep an eye on and talk about as things change too.
Okay.
What we see with a lot of this though is as one area gets better, the other areas get better too. So I don't want you like stressing out that, oh my God, I need to change everything right now, because you don't.
Okay.
You know, you're not that far off from where you want to be. I think that those are all different areas that you might think about.
Okay.
Okay.
Yes.
So from here, when do you think would be good to come back and talk some more?
Well, I'm gonna text Heather this week, so I mean, I could maybe at the end of the week or the beginning of next or something. Like maybe at the beginning of next week or the end of next week.
Okay. That's totally reasonable. And so whenever you go around to check out, just go ahead and schedule an appointment with me in 1 to 2 weeks. We could do video, we can do in person, whatever is going to be better for you. But go ahead and do that. Between now and then, if different things are coming up, if you're feeling like, oh wow, I'm suddenly feeling way worse, anything like that, give a call. We can always meet sooner too if needed.
Thank you.
But I would want to give it, like I said, at the beginning, it might might feel really forced and dumb. So I also don't want you to be worried if it's like not suddenly feeling better.
Okay.
Okay.
All right.
Questions for me right now? No? Okay.
No.
All right. Well, let's get you out of here today. Like I said, if concerns come up, then give a call.
Okay.
Otherwise, we'll meet in 1 or 2 weeks and we can strategize more from there.
Thank you.
You're welcome. Take care. All right. All righty. So that was 26 minutes, 25 minutes. Granted, Melissa was very cooperative and very nice, and people are not always cooperative and nice, but that is, and so I went through more interventions than I normally would. Like I tried to emphasize at the end, if you give people too many takeaways and they freak out and don't do any of them. So I went through a couple more interventions than I normally would, but also so that you guys could see what my different interventions look like. So then after the session, ideally right after the session, but I don't like writing notes, so I usually don't do it right after the session. I usually wait. I finished my note. But as you see, like the bulk of my note is there and it's done. You saw how I like jump around to different stuff to get it filled in. And so after the session, I would clean this stuff up. And most of it I end up leaving. I don't end up doing as much editing after. This is a bit long of a note. As you see, I write in bullet format. My goal of my notes is to make it readable to the providers. Mainly I'm writing the notes for them. Also because like legally I need to write notes and it helps me to remember things about people, but mainly it's for them to read. So you see in the note that I have who referred this person. They're here for the initial appointment. We looked at I looked at their problem list, their most recent questionnaires, and their care team who we have up here. We try and have everyone on the care team, so an MD/DO, as well as one of our APPs, either an NP or PA, that I introduced myself and talked about limits of confidentiality and the fact that I'm billing to insurance. All the stuff that they said. These are the health behaviors I try and get at all of my appointments. With my little kids, I typically don't ask about nicotine, alcohol, drug use, or sex or sexuality concerns. This is my this is my mental status exam, so I'll go through and like change it. Usually I'm just changing if they were their mood and affect. I'll put in suicidality. The rest of the stuff tends to be about average. You can't see my note. Well, then why? Oh, that's so distressing. You should be able to see my note because I'm screen sharing. Huh.
Any ideas why they can't see our note?
You might have to reshare your screen again. Yep, move out of that and then go back to reshare your,
You see
yeah, perfect.
Oh, gosh.
We've been trying to send you a message. No worries.
Sorry, guys.
No, we have time.
Alas, we tried. Okay, so this is what my note looks like. And I'll show you a blank version of what pops up before the thing, but you'll see who referred the patient, that they're here. Right now I'm typing, I will type in like, this appointment was in person per patient preference because it's COVID and I want the world to know that I didn't make them come in person and expose themselves to COVID. And then bullet format for my notes. Just all the things I asked about. Here are the health behaviors. We're gonna go through a second one and you'll see me typing during it, so I'm not freaking out about this. Mental status exam, assessment, the care plan. So I things that auto-populate, so I can write .plan and this pops up. I basically always normalize, validate, and give support. So I just assume that I'm gonna do that, although I can always edit it out. I have other hidden text things that, like, if I talk to someone about anxiety, here are the things I'm usually doing. We didn't go into as much about anxiety. I don't have a preset one for depression, although I should write something there. And the treatment plan, so collaborate with the treatment team and community supports, decrease symptoms of depression and anxiety, use CBT techniques of behavioral activation, cognitive restructuring, and relaxation strategies. We're probably not going to do anything with exposure. I could do an extra goal of like things like eating or sleep, but they kind of compress down into depression. So I would fill this out more later. I always have time in and time out because insurance wants to see that, because my coding, my CPT codes, I use the 90832 series, which is the psychotherapy codes. So this was a 90832 because it was a 30-minute appointment, which means it was between 16 and 37 minutes. Follow up. Here's where I write little notes about what I talked with the patient about that I will later go in and fill in terms of the comments. I'll also write a thing in here about, like, Audrey is a 20-year-old with symptoms of depression and anxiety over the past month. Usually this is about a paragraph where I write their symptoms, the main functional impairments, late to work, distress, and just a general thing that backs up the diagnosis using the DSM criteria somewhat loosely, but somewhat. So yeah, so I fill out that note. I like actually make it look pretty, which my goal again is for this to take less than 5 minutes to finish the notes. I hate documentation. I hate it so much. So I procrastinate doing it, but I always have the note done within 48 hours so I can send it to the provider. And then later on, I would go into the patient's chart somewhere else, and I would make a triage note where I would send to Dr. Gagnon, and I would say, here's another thing that I like have built into the record, is to just like autofill these things. Thanks so much for this referral. We're going to continue PHC support around mood concerns, but no major safety concerns at this time. And then I would add, again, this is like your note specific, how you would send it back to the people, but this is what I would do, and then I would send that. But I'm not going to send it because this is our medical record, and Dr. Gagnon doesn't want to read this. Okay, so now I'm going to do another weird thing to hopefully make this correct. Yeah. So this is what the blank one looks like. Those are the main areas I try and hit. like I said, trauma history, family history of mental health concerns, the patient's history of treatment if they have it, what school they go to, who do they live with, strengths. All of these health questions I do try and ask. Like I said, Melissa was really cooperative, but most people do kind of just answer the questions and don't want to spill their guts about everything. Sometimes they do, and I have to kind of corral them in, but usually it's okay. So this is sometimes what my notes will look like when I actually write them in, right? So this is a different case, right? But this is literally pulled from someone's medical record. Person is a 9-year-old with big feelings. It's a term I use a lot. Not very technical, but it's what I use, which sometimes leads to angry outbursts, going on for a few years, worsening with time. Primarily, the concerns are with one of the brothers, but schools start to notice concerns as well. Family history of anxiety managed by therapy and medication. If someone is on medication, I try and note what the medication is, because if one family member is responding well to Prozac, that was where we might start. Reported functioning well in other areas of life, just to kind of round that out. My intervention, again, like this is, if you're thinking about like SOAP notes, which some of you are more familiar with the structure of, so subjective, objective assessment plan. This is my like objective, this is my intervention, and then plan. So I do a lot of psychoeducation, recommend workbooks. Sometimes some families really get them and other families don't. So they're not my favorite intervention. And here's what like our plan is. And then the follow-up as needed if concerns are not improving. That's often my follow-up. Therapeutic techniques I use. So you can use any therapeutic techniques to fit into the BHC model. Some are a little bit easier to adapt to short-term things. I love CBT for insomnia. Do a lot of motivational interviewing. Some family systems kinds of stuff. That's more of my theoretical background in session versus the interventions I'm doing, but I do use some of the interventions. I love DBT, I love ACT. Oh, I'm like not even in the presenter mode. Okay. We're gonna circle back around to the warm handoff because we will have time for it. But some shortcuts, like I said, using your medical record, getting your note templates to fill in all of this stuff. I leave myself to-do items, which is a function of the medical record, where I can be like, oh, like I need to like talk to this person's therapist in a week, or like I should reach out to this person if they don't end up scheduling in with me. The like key to my life is building relationships with the medical providers, because if they don't trust you, if they don't know you, then they're not going to use you and it's not going to work. Adapt yourself to the medical world rather than waiting for the medical world to adapt to you, because it won't. Like I live in a medical center, and so I adapt to them. There are some reverse integrated places where like a primary care provider will come and work in a mental health clinic, but that's not how we work here. So I feel like I slowly seep into their culture and like try and rub off on them in like trauma-informed care kinds of ways, but by and large, I take their culture and I sit in it. Also, build relationships with everyone at the practice, everyone, because it's a team-based approach. This is team-based care, and that team comes from the front desk folks who are doing like so much overwork, to our nursing staff who are also doing so much of the care, and also with like the greater community, trying to really see this as a team-based approach, because that's the way to make changes. For finances, we bill for everything. I've been part of clinics where the BHCs don't bill, and I think that can be sustainable in its own way, because there's the whole value added thing where I'm not just doing clinical interventions with people, I'm also making it so providers aren't as burnt out, so that they can stay on top of their ginormous caseloads where they each have 2,000 patients that they're caring for. But also we bill for every session I have that's more than 16 minutes, which is an advantage I have as a psychologist. I know other degrees have much hairier times getting things paid for. We also bill for our screening tools. Sometimes insurances really suck at paying for them, so then we stop billing for them because we don't want our families paying for them, but a lot of the time we're billing. We're about break even for covering the finances of my position. I think a little bit.
A little more than
a little
that.
positive.
This is, so Northeast Pediatrics starting point with integrating a BHC started, well, like 11 years ago. I started doing developmental coordination here, which was, we had this need, we were referring children to early intervention, we were referring kids to developmental pediatrics. So we had this need to try to catch things earlier and implement screening tools, like Dr. Connor had mentioned earlier. So that was like my main responsibility, was to bring in the validated, reliable screening tools that were recommended and to implement them into the office and into the visits. And then when one came up and there was a concern, I would speak with the parent about where their concerns were compared to where the screening tool had indicated a concern. We talk about early intervention referrals, maybe some activities to help things. And then the care coordination piece, that started up about 6 years ago, and it also melded into my position, and it became a bridging point for people to get care to specialists or community partners and help navigate them. But so we started really, like, our BHC program started as like a level 2. Like, we had a list of therapists. We told I would have conversations with patients, you know, that said it has to be a good fit, you know, just because like you want a blind date, it doesn't work out, doesn't mean you're gonna stop dating, right? So go to the therapist. If it doesn't work out, it doesn't mean that therapy doesn't work. It just means maybe that's not the therapist for you. We'd have a good understanding, and then I would follow up with them. But we had this major gap of where we were missing, that we couldn't fill, which was giving people intervention now and here, and then springboarding them. And so we started, a lot of my position was compensated through the screens that were implemented. And then, you know, we had added a BHC who came in, and then left our practice, and we were without one for a while. When Dr. Connor came in, she had a really good understanding of how BHCs implement into Northeast Pediatrics. We had sort of started doing it, we just didn't have it to the degree that we needed it or that she could bring on.
It was more of a level 3, I would say, at that point.
You think so?
Yeah.
Probably.
Yeah.
Okay.
Because it was more of a traditional therapy kind of feel.
Oh, when the other BHC
yeah,
came
the other
in.
BHC.
I'm sorry.
Yes,
right.
yes.
So right, when the first BHC came on, it was more of like a level 3. There was a lot of, it was longer term sessions going on and such, and bringing patients back. And it's been a learning process. But to be able to start that anyway, to bring on the first BHC, we worked very closely with Care Compass and the district program. They jump-started things with some funding that we had applied for. And then the program started to kind of sustain itself through our BHCs billing for their work. And yes, it is tricky depending on who you have doing it, just because New York and insurance makes it difficult to bill for certain things. So our program, I think the starting point wherever you are is good, right? Just a starting point is good. And we certainly didn't hit the ground running with the presentation that Dr. Connor just gave. We didn't start the ground running with that. You know, we built up. We said, oh, there's a need, you know, parents want to talk about developmental stuff. I can talk about developmental stuff, but the doctor doesn't have time for that. And then, oh, now this person needs help getting hooked up with their developmental pediatrician or with developmental counsel or whatever. And then it just kind of, it rolled and it rolled. And as you get these things into your practice, and as you add these services, you're going to find out that everything runs so much more smoothly with them added. If you can find a way or funding to springboard, you can work out the kinks, then you'll find that this is incredibly helpful and makes everything a little more efficient for everybody.
And we're also not, you know, finished with figuring out what's working for us. We're still working on growing and expanding and figuring out how can we continue to fine tune this. There's no end date to, oh, now we have the whole thing figured out. We're continuing to figure it out every day. We make adjustments and we fine tune things.
Yeah.
Okay, so some resources that I love, and then we're going to do another quick role play, and then we'll go into questions. So like I said, so the Robinson and Ryder book is like my Bible. Oh, come back. So behavioral health or behavioral consultation in primary care. Same with the Hunter Goody and Dobmeyer book, Integrated Behavioral Health in Primary Care. Both of these books are like they teach you how to do this stuff. The Foreman and Shahidullah book is pediatric specific. So I did most of my training in the adult world, and then I was like, oh, maybe I should go work at this pediatrician's office.
We were like, yes, maybe you should.
And so this book was really helpful, as well as I went and did, like I said, an intensive training at Cherokee. They had a whole pediatric BHC training that was really helpful. They are like much further along than we are, and they have like a BHC incorporated in every single well visit, and like they're doing nutso stuff because they have 1 billion BHCs there, and they're really amazing and have been doing this for a long time. CFHA is like my professional home, more so than with the psychologists. Collaborative Family Healthcare Association. They're super amazing. They have a great listserv where clinics across the country are like, hey, like, how do I incorporate, like, how is everyone incorporating ACE screenings? And then people talk about how it works for them. And it's a beautiful, beautiful group that I highly recommend. And then, as mentioned at the beginning, we're a part of NCQA. We're like certified through them, and they're swell as well. Okay, so it's 10:40. So I'm going to circle back to this role play number 2, warm handoff. Okay, so in this scenario, I have a scheduled patient in 10 minutes, which is great because in 10 minutes we want to be doing the question and answer. So real life here. In 10 minutes, I have a thing that I need to do, but I get a call from a provider. And again, if you guys have preferences, let me know. Either we're going to do a teenager who was coming to an ADHD med check. You know, they got started on Ritalin 2 years ago, and every 6 months we check in on how they're doing with that. And then they admit that they recently cut themselves. Or a parent came to a well visit for their small person, and then they broke down crying because they don't know what to do with their kids with remote learning. And remote learning in the spring was a mess, and they like do not feel up for it for the fall. Both of these scenarios are things that I definitely get on a fairly regular basis. Or if you have any other thing that you would like to see in 8 minutes, now is your time to chime in. Otherwise, Melissa will get to pick.
I haven't practiced any of these and I have no preference. So really you can pick whichever one you want. Or if you have a scenario that's come up in your office and you would like a little idea of what that would look like, then throw it out there. We're okay with it.
You got 30 seconds to answer. Also, apologies for us being fast talking people. I want to acknowledge that is a thing about us. But luckily it's recorded, so if you want to go back through and listen again, I don't know that I would, but you can.
All right.
So
Whichever one you want to do. I don't care.
I don't know, because I feel like we already did the depression things.
We did.
So we can do like the crying parent.
Okay.
Okay, so I'm gonna try and do this the right way this time. And we're gonna cross our fingers that it works. So you guys can actually watch what I'm typing.
Can you see this?
Let me know if you cannot see this.
Like, can you see
Yes.
screen? Okay.
Wonderful.
You
Okay.
can go.
Okay. So a provider will come in and be like, listen, like this parent is crying in the room right now. Like they just burst into tears. I feel like I've gotten like several of these this past week. And so they're like, please come help this family. And I have like 10 seconds to look through the note, but I don't really. I basically write this.
I'm trying to get him to cry.
So the patients are, and the parent is already in the room. The patient will be this 6-year-old, that's fine. You ready?
Yeah, I'm ready.
Okay.
Come in.
Hi.
Hi.
Do you have a couple minutes to talk today?
I mean, yes, do you?
I do. So I'm Dr. Connor. I'm the behavioral health consultant here. So what that means is I'm a psychologist by training, but the way I work here is different than how like a therapist, your school psychologist might work. I work on the team with your kiddo's doctor, Dr. Akinyeti. I see folks anytime there are concerns going on where our well-being is being impacted by moods, behaviors. So if it's all right, we'll just talk a couple minutes here today. And then we can figure out moving forward what might be helpful. Is that all right?
Yeah, that's okay.
Okay, so you're gonna see I'm gonna be typing in our medical record. I keep in touch with Dr. Agagnon. I'm a mandated reporter of safety concerns, bill through insurance, that kind of stuff.
Okay.
Any questions about?
No, are there safety concerns?
Not
I'm
that
just like a little stressed, but.
not that I've heard of so far.
Okay.
It's just a warning I have to
Okay.
give everyone,
All right.
just so you know.
All right.
Okay. So it sounds like things have been really stressful lately.
Well, I know, I'm like trying to work, and my husband is a truck driver, so he's like halfway across the country, more than half of the time.
Yeah.
And I think I have Audrey, and then I have Ryan, and Audrey is like trying to learn, and I'm trying to help her with her on-school stuff. The meantime, Ryan's drawing with marker on the wall, and also work is calling, and I'm trying to do all of it, and it just feels like this is ridiculous. I don't know what people want us to do.
Yeah, that's so fair. It's so stressful.
It's ridiculous.
That's a lot.
I know.
How have you been dealing with all of that?
Honestly, I drink a lot of coffee, and sometimes I smoke a cigarette outside when my kids aren't paying attention.
That's fair, right? I mean, like it's a lot of things, right?
Yeah.
I think this time has been really impossible for most families, right? That you're being asked to do like 3 full-time jobs at once, and also the schools are not set up to be doing this. You know, like it's not like your kids are homeschooling and you walked into being like, this is what I want to do.
Right.
The world is saying, here are your 3 jobs. Please do them now all at once, and please be perfect at them,
Right.
or else.
Yeah, feels that way anyway, right?
Do you talk with other parents?
I don't really have time. I mean, sometimes
Yeah.
we will like complain via text, me and my friends, and it'll just be like, this is like a total like show.
Yeah.
And then they go back and we go back and forth about it. But there's like not much time. You know, I have to keep Ryan from drawing on the walls or flushing his toys down the toilet.
Right.
And then keep Audrey on task with her stuff.
Right.
And I don't know. Sometimes I get to talk to my husband if I have time, you know. It's just like super stressful, and I don't know what to do about it. Like I don't know how to manage it.
Sure, that's totally reasonable.
Like, do you know how to?
We can talk about things that might help. What school do they go to?
Oh, they go to Ithaca.
Okay.
Well, sorry, Ryan's not in school. Audrey goes to Caroline Elementary.
Okay. What grade is she in?
First.
And so they're doing 100% remote learning right now, and then in October, is it going to keep being remote, or are you going to do hybrid?
I don't know.
Don't know.
I'm too overwhelmed to think about it. And I don't even know, have they even given us options? I don't even know.
My sense is that in October, you'll either be continue to do remote, or actually with the elementary school kids, it is going to be, there is an option to do in-person schooling 5 days a week.
All right.
So
maybe
something,
I'll just do that.
and you know, who knows what the time will actually bring, but we're thinking about what's going to be a more realistic thing for your family.
Crazy times.
So what is your job? Like, how flexible is it? How much do you need to be in meetings?
I'm an
all day?
insurance agent,
Mhm.
and I am taking a lot of phone calls all day, which makes this super tricky because like a bunch of the phone calls are routed to my home phone because I work out of my house, which is nice. It's just that it's impossible, like totally impossible. So that's it.
So I think with this, the goal is to do the best you can and to survive.
Okay.
The goal isn't to completely
Cigarette.
So there's a range of coping skills.
Yeah.
And like maybe cigarettes aren't the things that help fix everything,
Okay.
but there are also worse coping skills too. Okay. So I'm not saying let's go smoke all the time, but I think you need to do what's going to help you get through this in a way that keeps everyone safe and stable.
Okay.
Okay. So I want you to cut yourself some slack, number one,
Okay.
and realize that we are in a pandemic, that like this isn't like you decide to homeschool your kids and you need to like give them the best education possible. That this is a pandemic, and as a society, we are going to do the best we can. And I think there's an acknowledgement that it's not going to be perfect and that that's okay. So your goal isn't to perfectly be the like perfect teacher for your children. Your goal is to do the best you can to balance this stuff.
Okay.
I do think it might be a bit easier to balance this if we could get you a bit more support. I don't know how realistic that is, right? So like sometimes there's some wiggle room with your work or with dad's work or with like potting with another family. So maybe you connect with another family with similar age children and say, you're gonna watch the kids every other day, I'll watch the kids every other day, and things can be worked out that way if it feels safe to do, granted like pandemic, right? And so can you think of, is there any way that we could get a bit of extra like grown-up power involved or
Like, I don't even know.
Yeah.
I'm gonna have to like think about it. I think it's a good idea. I just need to know if I have like ability to do that with the people that I know.
Yeah, absolutely. That's totally fair. So those are the things that I want you to be on the lookout for. Mainly, I want you to cut yourself some slack. Remember that you do not have to be perfect at this. That's totally okay. That the teachers are going to do the best that they can, the parents are going to do the best that they can, and that we're in a global emergency and we're just going to do the best we can for kids. So if they don't get their work done perfectly, I think that's okay, right? Like we just want to do the best we can. I hear how much you love your kids. I hear how hard you're working.
Ugh.
If we could get you a bit of extra support, I think that would be great, but I know it's not always feasible. Even if you can take like a minute every hour and just take the deep breaths and remind yourself, we're in a pandemic, I'm doing the best I can. I think that's helpful. If we could connect you with another parent who's going through the same exact thing, because I talk with parents every single day who are going through the same exact thing, you're not alone, then that might help too, to get some more teamwork around this.
Okay.
Would it be helpful for us to circle back in like a week and you would just like check in by phone?
It might
talk
be.
about it?
It might be.
Okay.
Yeah.
So let's do that. Let's talk about that then. And because like I said, I think that you're doing really good stuff. I think that it's just a really impossible situation and you're just going to do the best you can. Okay.
Okay.
Any questions for me today?
Do you have a cigarette?
I do not. But when you check out, just go ahead and pick a time next week where we can touch base by the phone or video, okay?
Okay, thank you.
You're welcome. Okay, so went 1 minute over. That's all right. I'd be 1 minute late to my session. I'm also used to being late to my sessions and my patients get used to that or they decide they don't want to see me, but by and large they get used to it. So then I come up with a plan. My intervention is largely like normalization, validation, support were provided, right? Like nothing revolutionary was done in that session, but there was a lot of normalizing, a lot of validating, trying to encourage support. The goal in a single session is not to fix the person's life, right? The goal is to like give them a little bit of something and help them move forward. So I would finish off this note, then I would go and put it into the well visit appointment note so that they're paired together. I wouldn't be able to bill for this service because it was 9 minutes. That's all right. That's what that would look like. So, Pukam, I will warm handoff over to you because we are ready for the questions. And hopefully we'll have answers.
All right. Well, thank you so much. That role play was so engaging and so interactive. Thank you so much for putting your own spin to it, Melissa. And definitely throwing Dr. Connor for a few loops, right?
Right.
Parents always say weird things, so.
For sure. Thank you so much, Dr. Connor and Melissa. So I'm checking the Q&A chat and there appears to be absolutely no questions at all. I mean, we've answered 4 of them on the suicide risk assessments and screenings, and we touched base a little bit on integrating the ACEs screening into the medical clinic, and then there were some video role plays. Are there additional questions from the attendees? That if not, I think it's been a fabulous session. So I think I'm going to take that as a no because you did such a fantastic job, both of you. Thank you so much. So I also would like to point out that the attendees will be receiving a short survey about the session. So please fill that out. We greatly would appreciate your feedback. And so on behalf of Care Compass Network, thank you so much for joining us today. And thank you to Dr. Connor and Melissa, and also our back-end team, Melissa Gussman and Kimberly Slezak, for helping us, making this a fabulous session webinar. Thank you. And I will give back 6 minutes to everybody's time today.
Wonderful.
Thank you. Good luck with everything.
Yes, thank you. Bye-bye.